Well, good morning, everyone. I'm Patrick Collins. I'm Vice President of Community and Corporate Affairs at NORD. And before moving on to the next panel, just wanted to say thank you to Viri, Gina, Rigo, and Magnolia for what great perspectives and takeaways that they shared with us today, and just how valuable it was. So thank you very much for that previous panel and that previous conversation. Buen día, como puedes ver, ahora tenemos los subtítulos en español y funcionamiento. Muy bien. Like that, huh? Did that just for you, Vinny. Our next session is one I think will be of great interest to everyone. We often hear from our community that navigating insurance is one of the biggest challenges faced by rare disease patients and families. In this session, our panelists will share their unique perspectives and provide helpful resources to navigate these barriers more confidently and effectively. So joining us today to dive into this topic, overcoming insurance barriers in rare diseases, we have the following. We have Alicia Lawrence, who is a licensed social worker and is also the Information and Resource Services Manager at NORD. And she is joined on stage by Jennifer Shumsky, who is a registered nurse, a certified HIPAA compliance officer, a prior authorization certified specialist, as well as founder and principal at JLS Consulting. We also have April Hall. April is the assistant professor and associate director of research for the UW Genetic Counselor Studies Program at the Department of Pediatrics, Division of Genetics and Metabolism at the University of Wisconsin School of Medicine and Public Health. And lastly, we have Thayer Roberts. Thayer is the Deputy Director at the Partnership to Improve Patient Care. So with that, I turn it over to Alicia to lead the session. Thank you.
Hi, good morning, everyone, and thank you again for joining us today and on this important topic, overcoming insurance barriers. Today we have a great team of panelists who will be able to provide some information that may be very helpful to everyone. We will start by asking our panelists to provide a brief introduction, which was already done, but just again. Jennifer? April? Sorry.
Hi, everyone. I'm April Hall. As you said, I'm a genetic counselor. I work with our UW Undiagnosed Disease Program, where we can offer kind of cutting-edge genetic technologies to patients and really genetic testing that's not available on a clinical basis. I also work with our Baby Badger program. So this is a program where we offer rapid clinical testing to critically ill newborns by really providing education to non-genetics providers, because we know there's just not enough genetics providers to go around to be able to offer genetic services to all. And also I'm on the, I co-lead the Insurance Alignment Committee as part of the PLUGS, which is Patient-Centered Laboratory Utilization Guidance Management, where we really work with insurers to develop policies and really increase coverage of genetic testing.
Jennifer?
Hi, as I was introduced, I'm Jennifer Shumsky. I've been a registered nurse for almost 30 years, and during that time I've worked a lot of different jobs, as many nurses have done. But kind of what got me here was, about 19 years ago, I was home for a year after having a baby, and I went to go work in insurance. And 2 weeks into that job, my 4-year-old son was diagnosed with Duchenne muscular dystrophy, which is one of the more common of the rares. And it kind of set my path in life, where I became a parent and caregiver to a rare disease and learned a lot about insurance. I worked in utilization management with a priority on appeals, denials, and policy writing, and did that for many years, and really helped me take that focus to start working within the rare disease community with the Little Hercules Foundation. Some of you know of it, where we helped families who are dealing with denials of medically necessary equipment and medications. And I just kind of took that on my own, and I do that on a consulting basis. And so I know that was long, but
Great. My name is Thayer Roberts, and I'm the Deputy Director with Partnership to Improve Patient Care, or PIPC. PIPC is a coalition of patient advocacy organizations and disability advocacy organizations, and our main focus is patient centricity within the healthcare system. And in recent years, we've needed to focus a lot of that energy on patient centricity within, basically payers, in terms of ensuring the appropriate treatments are covered and available to patients when they need them.
Thank you so much. So I thought we'd start off maybe by just simple terms as it relates to insurances. So as it relates to Medicare, Medicare is a federally funded program that is usually for individuals who are 65 and older, certain younger people with disabilities, and people with end-stage renal disease. We also have Medicaid, which is federal and state funded, but it's more of a state program, and usually every state has its own, and it covers the cost of people with limited income resources. The federal government does make the rules for it, but Medicaid programs must follow, but each state runs their own program. Then we have the health insurance marketplace, which is for those individuals who do not meet the requirements for Medicaid, but are able to possibly pay a smaller premium under that program. And then we have our commercial health insurance, which is usually what is through private employers, that like Aetna, Blue Cross, things of that nature. So why don't we now start with, also we have approvals, denials, and appeals. Approval is insurance plan is what usually is covered. You don't usually have any issues with that. Denial, of course, is what I'm sure we all dread, and where an insurance company refuses to pay for services and treatments. But it's important to know that you can appeal it. It's your right. And with that, we will start. So, April, let's start with your with Diagnostic Odyssey, in particular, the access to genetic testing. Can you share a little bit about the process and the barriers faced by families along the way?
Yeah, so a lot of individuals, I talked to a lot of individuals last night and even this morning about that diagnostic odyssey, right? That odyssey can last on average 5 to 7 years. I talked to some people this morning who've been on a diagnostic odyssey for 20 plus years. We know that they've seen multiple doctors, and they've incurred significant medical costs, and had that psychological burden of going through that diagnostic odyssey. For a lot of families, we know that genetic testing can be an important part of that diagnostic process. And getting a genetic diagnosis can really give you the answers to what is that underlying cause of all these symptoms that I'm having. However, and we know that with genetic testing, when you get that genetic diagnosis, oftentimes it can lead to more precise management. It can lead to specific treatments for your condition specifically. It can help you find a community of individuals who have that same genetic condition. And it can also reduce that psychological burden of being undiagnosed, going through that diagnostic journey. However, we know that there's a paucity of insurance coverage policies for genetic testing. And even if a policy does exist, it can be pretty limited as far as really granting approvals of genetic testing to individuals who meet those medical necessity criteria. And therefore, yeah, I think a large barrier is gaining insurance access to that genetic testing. We know that with those lack of insurance coverage policies, oftentimes patients aren't getting the right test that maybe they need. They aren't getting that biggest, most comprehensive test, looking at all of your genetic information. You may be familiar with tests like exome sequencing or genome sequencing. And if there's not an insurance coverage policy for that, maybe you're getting a better test because insurance isn't covering that. We know that in the United States, 38 Medicaid programs have coverage for exome sequencing. Only 9 states have coverage for genome sequencing. And we really think that genome sequencing is the test that really looks at all of that genetic information and is a great test in helping individuals find that diagnosis. A lot of times with that prior authorization process, you get that. If you get that approval, great, going forward with that genetic testing, but oftentimes reimbursement isn't there either. So hospitals aren't willing to support ordering that genetic testing. Diagnostic labs may not get reimbursed for that testing. And so even on that side of things, there can be barriers. If you do get that denial for genetic testing, that can come about for multiple different reasons. One common denial reason is it's not medically necessary. And oftentimes the provider may think it's medically necessary, but maybe those codes that were inputted aren't necessarily matching up with what the insurer thinks is looking for to approve that test. And also sometimes, so a test can be denied for because it's not medically necessary, or sometimes it's experimental or investigational. I think we see this a lot with genetic testing. There's a new genetic test coming out every single day. And so insurers have a difficult time just kind of keeping up with these rapidly advancing genetic technologies. And so they see a new test come out, and we're like, even genome sequencing, we're like, yep, this is the test. Like, this is a great test as a genetics provider. But the insurance companies are like, whoa, what is this test? We don't have enough information. We don't know necessarily what this is. We're going to deem that this test is experimental and therefore deny the testing for that reason. You do, as Alicia mentioned, we do have the opportunity to appeal those genetic tests. If it's deemed not medically necessary, oftentimes you can argue and present your case to the insurers, kind of really demonstrating how do you meet those medical necessity criteria. I highly recommend going to the specific insurance policy, even calling them saying, what is your policy on this specific genetic test? What are your medical necessity criteria? So when you are appealing that test, you can really detail how exactly you meet those criteria. If your test is denied because it's experimental, that's oftentimes a lot more difficult to be able to appeal. It's hard, you can argue for medical necessity, but if they deem that it's experimental, it's not part of their typical codes that they've seen before, oftentimes that relies on policy, actual policy changes that need to be advocated through that insurance company to get that testing covered. And yeah, that's kind of the appeal process.
Thank you. Jennifer, I know you have a unique perspective, being a patient, a caregiver, and a consultant. How has your professional knowledge helped you to navigate the appeal process? Also, is there anything you wish you had known sooner that might be helpful to the audience?
Sure. What has been helpful for me is, for both of my kids, my daughter also has type 1 diabetes, and for both of them, we have they have medications that have 6-month prior authorizations, and we've been doing these prior authorizations for probably 6 years. Every 6 months, like clockwork, it's prior authorization time. And it seems like there's a different person doing the prior authorization every 6 months. And I've anticipated it. I know what our policies are. I have more knowledge on the process usually than the person that's going to be completing it, but of course I can't do it. So I have the ability now, in anticipation, I reach out usually through our health portal. I attach all the documentation. I give them the exact wording. I say, you're going to call this phone number, you're going to ask for a reauthorization, do not ask for a new prior auth, that will screw everything up. You need to tell them this was the date, these are the reactions, this is the reason why. You're going to attach, for my son, these are the scientific articles you're going to use to say why it's medically necessary. For my daughter, this was the reaction, this is why. sometimes I get pushed back because they're insulted that I do it. Usually, though, they're thankful that someone has made their day easier, but it can vary. So that has been really helpful. Also, just with other denials we've had, having that knowledge to know how to read the policy. I think that is honestly knowing how to read a policy, so knowing what's going to be needed, and then also knowing how to read a denial letter. That honestly is the key to many times getting an appeal overturned, is understanding exactly why it was denied, so you know exactly how to appeal it. That makes a big difference. Things I wish I would have known sooner, even to this day, is, this was mentioned in the last panel, we are the experts on our medical conditions and our diseases, and we are the keepers of our own information or our child's information. We all have the big binders. Unfortunately, a lot of us just have a lot of paper, but we have the dates, we have the information, and no matter how many times we might tell a medical professional this information, it doesn't always make it in the chart. And I have found we've had experiences, it's really annoying that if the insurance doesn't get that piece of medical information, something gets denied. And then we go back to the insurance and we say, well, no, that's not true. We did try this medication and failed it in, November of 2010. And they say, well, it's not in the medical record. I can't take your word for it. And I'm thinking, well, I'm a medical professional. It's in my record. I wrote it down. It's right here. And it's very frustrating. Or like failures of medical equipment. I know in our community, we tend to, why would I buy a brand new hospital bed when my friend's, son, perhaps is no longer with us and they have a hospital bed to share and they're going to give it to me. So I'm going to take that free hospital bed and try it out. And that hospital bed did not work for my son, so he didn't like it. So we have now tried and failed the standard hospital bed, and we're going to try to get a specialty hospital bed, and one of the criteria is you have to have tried and failed a hospital bed. This was something that happened to us. And my insurance went through my claims and said, well, we've never paid for a hospital bed. And I said, well, of course not. Why would I charge you for a hospital bed when I got a free one? And it didn't work. And this was Medicaid. We went all the way to fair hearing. We're sitting in the fair hearing, and our state Medicaid medical director was like, wait, you tried one and failed it? And I said, yes. It happened to be free. I didn't want to cause you the expense. And she's like, well, why didn't you tell us this? And I'm like, well, I did. And she's like, well, you could have saved us so much time. So I think that is still the most frustrating thing is I can't tell you how to fix it other than just, know that we understand. But that is why keeping your own records and do everything in your power to make sure that your records get into the medical chart somewhere so that it can be got to the right people at the right time, I think is things I wish I would have known, but now I do know and can't fix all the time. But what you do is very important, and I know you're all doing it because we've all know this.
I think just along with that, it's just important also to, if you are able to access your medical record, maybe after a visit, just go into the portal and make sure that whatever you spoke with your provider about, you see that it's there. If you have access to do that. Thayer, in your work with PIPC, could you talk about regulatory and policy changes that patients and families should be aware of as they work through these barriers that we're talking about today?
Yeah, absolutely. Thank you, Alicia. So I'm going to kind of pull us up 10,000 feet. We've had a lot of really tangible conversation of dealing with your actual denials, I'm going to step back and talk a little bit about why you might be seeing some of those denials and red flags to look for and how to proceed from there. So thankfully, there's been a lot of interest in recent years from policymakers in addressing some of these challenges. That being said, Capitol Hill moves slowly, especially now. So, I'm hopeful that we'll see some oversight of payers that will impact some of this, but in the interim, it's really important as patients and caregivers that you understand kind of why some of these things are happening, what the red flags to look for are, and what levers you have to help you address that in your appeals process. So Jennifer helpfully teed us up by mentioning it's important to know the reason for your denials. And I'm going to chat about two reasons that we're seeing a lot more frequently today. One is drugs that are being denied because they were approved via the FDA's accelerated approval pathway. And the other is treatments that are being denied due to the use of discriminatory value assessments. And those are both pretty rampant right now, unfortunately. And they're both really technical too, so I'm gonna go real high level, but I am happy to answer more questions or provide more resources as helpful after the session. So starting with the accelerated approval pathway, as a mini primer, the accelerated approval pathway was established in 1992 in response to the HIV and AIDS crisis, and the goal was to get treatments to patients with serious disease with unmet needs faster. So the accelerated approval pathway allows FDA to approve a treatment based on a surrogate endpoint. You may have also heard that referred to as a biomarker. And basically, the treatments are still highly effective. They still, FDA, it's a full approval. It shouldn't be looked at as anything less, but it allows FDA to get these treatments to patients faster. And this is critically important, especially in rare diseases, because as you all know, population sizes are small. It can be really, really hard and take a long time to set up huge placebo-controlled clinical trials. So this is a really helpful tool for patients to be able to access treatments faster. Unfortunately, a lot of these treatments are expensive and payers are looking for ways to circumvent paying for them, right? And so what we're seeing is many payers, both commercial and Medicaid, are starting to deny treatments approved by the accelerated approval pathway. And what you will see in these denials is generally, to April's previous point, is that the treatment is either experimental or investigational. So if you see those words, that's usually a pretty good flag that this is what you're dealing with. I would recommend, if you find yourself in that situation, to connect with your disease-specific patient advocacy organization. If you are having that challenge, you are not the only one. Jennifer mentioned Duchenne. Little Hercules Foundation, I know, has been doing a lot of work on this in Duchenne. They're not alone in other diseases. There are other organizations that are doing that work. If you need help locating that group, I'm happy to try and make those connections. Another avenue that you can go is oftentimes if you call the patient assistance line of the pharmaceutical company that manufactures the treatment that you are having trouble accessing, they can sometimes, if you're getting denied, you're not the first one, right? So they can sometimes point you in the right direction of a group that is working on this, or, resources that can be helpful to patients through that process. So it's not a silver bullet, and it's really unfortunate that it's happening, but I think it's important to be aware of, and those are two avenues that you can pursue to address it. The other piece that I want to quickly mention is denials based on discriminatory value assessments. So this is super wonky, so I'm going to give like the 1-minute explanation, and I'm happy to provide resources. But there are a type of analysis called cost effectiveness assessments that are purported to determine the value of a treatment. The reality is often these assessments are designed for payers, and they determine the value to payers less than the value to patients. Most of them do not include outcomes that are important to patients, and the vast majority of them rely on a discriminatory metric called the Quality Adjusted Life Year, or QALY. I'll do a quick aside that there are other metrics that are under development, as the QALY has been found to be roundly discriminatory. I'd still be cautious about some of those at this point too, because they're untested, and the data that we have underlying all of this, particularly as pertains to rare disease, is not very good right now. It's hard to have a kind of rote equation to determine what a patient needs, right? So I'll leave that there and go back to the QALY. But the QALY, how it works is basically by assigning a value to a year of life. So 0 is death, 1 is perfect health, and every condition is assigned something on that sliding scale, right? So maybe you're a 0.2. And the way these assessments are conducted is more value is given to treatments that can get you back to perfect health, so that can get you to that 1. We all in this room know that with rare diseases and diseases that cause disability, the goal isn't always to get to 1. You're not going to get to perfect health, but if you can improve your quality of life, that is very, very important. But that's not how these are set up. So often if payers are relying on these assessments, they will the assessments will undervalue treatments for rare diseases or disabling conditions, and then the payers will say, well, they're not valuable based on this assessment, we're not covering them, this other treatment is better, and we'll refer you back to, steroids or whatever kind of the basic past supportive care treatment is. And that's a real problem. So sometimes it can be hard to determine if your payers are relying on these, because as we all know, payer documents can be really opaque. I would say poking through documents, or if you're looking at Medicaid programs, P&T committee meetings, which should be public, they aren't always, but should be. There are some key things to look for. Generally, if they cite entities that are known for conducting this type of assessment, that's a pretty good flag. And I would say the main ones to look out for there are the National Institute for Health and Care Excellence, NICE in the UK, CADITH in Canada, or the Institute for Clinical and Economic Review, or ICER, or Portal, which are independent entities in the US that payers refer to for this too. So just kind of helpful keywords. So the good news about this one is if you are able to point to that as the reason, you do have some recourse here. So the use of the quality adjusted life year and similar metrics has been banned in Medicare for quite a long time. There's currently a bill that has passed the House in Capitol Hill. I'm hopeful it will pass and be signed into law at the end of this year that would ban the use of the QALY and similar metrics in all federal programs. That would be hugely helpful if it came to fruition. Crossing fingers in today's political environment, but it would be great for the patient community. But they're very pertinent to this. Just in May, the final rule that governs Section 504 of the Rehabilitation Act, which that's wonky, but it's the piece that handles making sure that you can't discriminate in programs that get federal funding. So it's what governs ADA type stuff, right? So taking it down to baseline, you can't discriminate against people with disabilities if you get federal funding. So it's the rule that manages that. And that rule is most recently said that payers cannot rely on metrics that devalue life extension. So that would capture the QALY, and that would capture several other similar metrics. So and I'm happy to point you all to that section if it's helpful, but that governs Medicaid programs, it governs the exchange programs that Alicia was just talking about, so there is some recourse there now for those plans. And the Office for Civil Rights has been very vocal that they intend to enforce this broadly. So I think, we've started seeing some of that percolating. I think payers are going to become more aware of this as an issue, and it does give you a little bit of recourse to push back in an appeal, should that be the issue. So that's my hour spiel distilled down to 10 minutes.
Thank you. So what are some things that patients and families should consider when choosing an insurance plan? Jennifer?
Sure. We have a little resource up here. One thing, at least if you want to know if you're choosing an insurance plan through your employer, one thing you want to look at is how is that insurance funded? It's something that many people never really thought about, but it's becoming, more important. Is how is that insurance plan being covered? Is it a fully insured plan, or is it a self-insured plan? Basically, this kind of talks about the difference between it, but basically with a fully insured plan, the employer is paying all or part of the premiums to the insurer, and the insurer pays all the claims. With the self-insured plan, basically the employer, the employees, they're paying for that health care. And the difference is those fully insured plans, your coverage has to follow those ACA guidelines. Self-insured plans do not. They're governed under ERISA, which I cannot remember. It's the Employee Retirement and Securities Act of 1974. But under those self-insured plans, they have to have, they have separate guidance. And, you could ask, like, when you get to open enrollment, it might be, you're looking at the coverage, and they might have Blue Cross Blue Shield and United Healthcare. And that under your rare disease, you might have a new cell and gene therapy coming out. And you're like, oh, I know that United Healthcare covers it, but Blue Cross Blue Shield doesn't. So you decide to go with the United Healthcare plan. But what you didn't realize is under your employer self-insured plan, they have a specific plan document that states that your employer does not cover any cell and gene therapies. And they are allowed to do that under ERISA. So it doesn't matter which plan you chose, and it doesn't matter that United Healthcare covers that therapy, because your employer has decided they're not going to cover that therapy. So it's just something to be careful of and know about. It's something, obviously, at a regulatory basis we need to start working on with the Department of Labor. But that's just something to think about now with your employers, and something to find out early.
Thank you. And April, really quickly, what can patients and families do to take action?
Yeah, I think on the legislative, we've talked a lot about some of the bills that are out there, but each one of you is such a powerful voice. Legislators really want to hear from their constituents, and you all have a strong voice in really advocating for increased insurance coverage of diagnostics or treatments. And so there are several ways to be able to do that. It can feel a little bit overwhelming. One thing is to look if your state has an RDAC, or a Rare Disease Advisory Council. NORD has done a great job in really trying to set up RDACs in every one of the states, but if there are those groups in your state, become a part of them, because they're really able to advocate for some of those policy changes at that legislative level. And if there isn't one in your state, helping to set up an RDAC in your state, I think is a great avenue. But all of you, you are able to vote, and you're able to meet with those people that represent you. And so, reaching out and setting up a meeting. Most people have easily accessible on their websites. You sign up, and NORD, I think, even has ways that they would be able to attend some of those meetings with you, and they can kind of talk about those legislative side of things, but you can talk about your own personal story, and those have such a strong you have such a strong voice, and the legislators really listen to those voices. So advocating for those policy changes, I think, is so important.
Okay. Thank you so much. Thank you to each of our panelists for sharing their invaluable thoughts. And as we collect questions, would any of you have any final thoughts you might like to add to our discussion?
I mean, I'll echo April that your voices are critically important, both on the state and federal level, as we're talking about policies that impact patients with rare diseases, particularly access, which is a huge issue right now. So, please do kind of lend your voice to this effort. You do make all the difference.
Again, I just want to, oh, Jennifer, did you have something to
I
say?
just want to make sure, as everybody said, never take a denial sitting down. Always know you have appeal options. You can find resources. NORD is always available to help you with that, but appeal. Never take a denial.
Love that, yes. Okay, thank you again to our panelists for this great discussion, and we are waiting to hear from Tiffany with some questions.
We have several coming in. If you have a question card that you'd like collected, please hold that up high so we can see. This one is, health insurance companies often deny referrals for specialty care or end up only approving referrals to specialty doctors who are uneducated on my specific rare disease, which complicates the fight for quality care. Why do insurance companies deny referrals so often, and what can be done to help educate our care teams about our rare disorders so we don't have to continue trying to find insurance and better referrals ourselves?
That's a tough one. I think bottom line, they deny it because they don't know any better. I think there's not enough literature out there, for them to understand that your local neurologist because that's my role, just doesn't know enough on the topic. That's where, unfortunately, you need to appeal to get to a higher level of appeal where they have to use a truly knowledgeable person to review that need. It's really just a lack of knowledge on the insurance. I think the RDACs are really going to be the way to try to get changed in each state.
That, Jen. This one is, if an ultra-rare disease gets full FDA approval for the first ever treatment, does Medicaid and private insurance have to cover it? And if not, what steps can be taken to get an approval?
So Medicaid has to cover FDA-approved treatments that have a rebate agreement with CMS. So that's kind of the criteria there. We still fight Medicaid programs on this every day, and it is a challenge. But knowing that is critically important, because your state Medicaid program, and I'll kind of step back to what I said before, accelerated approval is full approval. So whether it's accelerated approval, whether it's the traditional approval pathway, it doesn't matter. It's approved by the FDA. So Medicaid programs have to cover it. Private payers have a little bit more leeway as to what they cover. Jennifer did a really good job explaining the difference between self-insured and the plans that are governed by the ACA. There are nuances there, and that's why it's so critically important to read your plan documents and to understand what your plan covers and what it does not.
I just want to add on that, though. Medicaid has to cover, but that doesn't mean that they can't put prior authorizations in place, and those prior authorizations can be very restricting.
Yes, absolutely.
We have a lot of questions here, so we'll try our best to get through most of them. It says, do you know any companies or resources who have been successful in approvals of life insurance once you are given a rare genetic diagnosis?
No.
Sorry.
No.
Was an easy one. What suggestions do you have for subpoint if you have an ultra rare disease that does not have an advocacy group?
Can you just repeat that for what? What suggestions for?
It's support. I'm just
support.
It was a little hard to read.
No, you're good. I think that relying on the umbrella groups like NORD is really, really critical. It's great that you are here. There are a lot of resources. I also think, unfortunately, it forces you to be your own advocate a little bit more, and it forces you to build those relationships yourself, and that's not necessarily fair. And I know you have a million jobs as is, as a patient or caregiver, and whatever your regular job is, and all of the things, and it's kind of layering one more thing on. But I would suggest you develop relationships with your RDAC. I would suggest that you develop relationships with your federal senator and representatives' offices. I would suggest that you on your own do that and make sure that everyone, that the key decision makers know about your ultra rare disease. And that's a bad answer because it puts more work on you, but that would be my suggestion.
Yeah, and if there isn't an advocacy group, I was talking to a parent this morning who started their own advocacy group, and just posting something on Facebook, they found other people who had that same condition. And so I think with a lot of the social media outlets out there, even just, if you're willing and able to post something, and then it can lead to another person with that same condition. And so, yeah, I think there's a lot of avenues with social media expanding to be able to connect with individuals.
This one is asking for advice for transferring the advocacy burden when dealing with transitions from young adult into adulthood and the insurance barriers that come with that.
We went through this just personally. Part of the issue is we didn't want to transition to adult doctors necessarily. Our issue was our pediatric doctors were not licensed to see anyone over the age of 21, so we were forced to do that. So understanding that you might not have a choice from a licensure standpoint, but I think, this is where advocacy, I know, wasn't there some of the table discussions were surrounding that transition. So I think just it's truly just a matter of education. I think the hardest part right now is a lot of our rare diseases, we were told not to expect to live to adulthood. And then we had all these innovation and therapies, and now that they are living into adulthood, the medical community didn't catch up fast enough. And so we are stuck. And so I would like to see more clinics established that are, lifelong clinics that expect them to be lifelong into adulthood. But it's not a great answer, but I think it's something that many communities are facing, and it'd be great if we do it together rather than in our little bubbles. And I think that is something where NORD is in a great position to be helping everyone out.
Great, thank you. This one is, how do you find out? Can you hear me? There we go. How do you find out when selecting an employer plan whether the plan is self-insured or not? Do they have to disclose ACA versus ERISA in a specific place, or where can I find that in the plan documents?
You should ask, and HR will say, oh, I don't know, but they are able to find that out for you, and they have to give you a summary plan document that then will tell you what is and isn't covered. As far as if it's a self-insured plan, that's where you find out if certain things aren't covered. Some plans don't cover genetic testing. That's another common thing you find in there. So, and that's, even when you're, interviewing for the job, if that's something you want to find out before you take a position, you can ask that, and they should be able to find that out for you. But it can take a couple weeks. I mean, that's one thing. I will admit, I didn't know, my husband's been at his job for 27 years, and I didn't find out until last year. So,
thank you. How can we fight denials in therapy services due to the lack of progress? It feels similar to quality of life discrimination, but stability is also equally important.
That's a hard one. If you're on Medicaid under the age of 21, and I always get the EPSDT is one way that my coworker Amy Akins, shout out to her because she's amazing, has been able to get therapies covered for kids. Some ways we've seen is if policies for therapies have coverage for habilitative versus rehabilitative, You know, a lot of therapists don't know to look for that language, because we're not looking necessarily to rehab someone. We're looking to keep them at their stable functional level, and that's a very different type of policy. So habilitative, look for that.
Great. What if the testing we believe is needed is denied? What is next, and how can we fight, especially when racing against a clock?
Yeah, appeal. Really look at that denial as to why it was denied. I would throw out there, Plugs does have a prior authorization toolkit for patients. It really walks you through, how do I look at that denial? Why was it denied, and how do I submit that appeal, using all the language that the insurer is looking for in order to get that testing covered. So yeah, appeal, really understand what that denial is, and I would recommend that Plugs prior authorization toolkit. As Jennifer mentioned as well, the EPSDT, that is a federal mandate that states have to provide. It's coverage, it stands for early periodic screening, diagnosis, and treatment. So even if there's not a policy for genetic testing, for example, EPSDT does cover things to provide early diagnosis and treatment to ameliorate some of those health conditions. And so in Wisconsin, for example, we use the EPSDT benefit to get genetic testing for our patients. Even though there's not a policy, using that EPSDT, we can get that genetic testing. There is a treatment clause as well. Every state kind of defines what their medical necessity is, and so tailoring your appeal to exactly what that medical necessity language is for the policy or for EPSDT to overturn that denial, I think is critical.
Great. This one is, is there a resource to find an insurance navigator to help families guide this process?
For the healthcare marketplace, yes. If you're getting through the marketplace, there's insurance navigators. When you're looking, if you have to choose a Medicaid plan, your state Medicaid should be able to help you. Same for Medicare. But if it's like through your employer plan, you have HR, unfortunately, and not all HR professionals are as good.
Thank you. This one asks where the information can be found of the states that will pay for genome sequencing.
Yeah, I Googled genome sequencing and which states have policies for that. There are 9 states currently that provide rapid genome sequencing. I couldn't name them offhand, but yeah, come up and talk to me after the talk, and I can give you those names. And yeah, I know there's a lot of efforts to really expand coverage of genome sequencing to multiple different states. So if you're in a particular state and have questions, yeah, I can link you up with some resources.
Thank you so much. If your question was not answered, I know we received an abundance. This panel is very approachable, so feel free to find them after the session. I'm sure they'll be happy to answer those additional questions. Thank you all.
Thank you.
Thank you.